start with DA video and DA presentation. So direct anterior approach, there is renewed interest in this because improved instrumentation, newer implants which are DA compatible, the smaller incision, rapid recovery, less post-op pain, shorter OR time in experience hand obviously, because in early phase of your DA career, you will end up spending twice or thrice the time what you need for a routine THA, and less chances of dislocation with DA for sure. But there are disadvantages: long learning curve, high incidence of femoral fractures in initial phase, injury to lateral cutaneous nerve, thigh, special instrumentation you need for that, and visitation is a must. Okay, and you need image intensifier. Planning, there are surgeons who do templating. It is ideal for THA. You should do templating each and every case, but for DA, it is must. So while doing templating on a femoral size, for example, you end up with size 5 on template, and while in actual doing the case, you get tightness in size 1 broach. That means your direction is wrong. So templating is very, very important for DA. Okay, positioning on routine table, adhesive strapping. I have a detailed video of the same. I will show you in a minute's time after this presentation. So both leg preparation is necessary. Incision is about 2 centimeter below ASIS, and from that point connect it to the fibular head, slightly oblique incision, okay? And it is intermuscular plane. So from inside the incision you can palpate ASIS, and you retract, so you deepen the incision, you incise the fascia over tensor fascia femoris, and then with blunt dissection, with finger dissection, you can go underneath that fascia, retract it, and then you find a plane between tensor fascia femoris and sartorius. So you retract tensor fascia femoris laterally, sartorius medially, that is the intermuscular plane, and then you are on vastus vessels. That's where you see these blood vessels which you need to coagulate thoroughly, otherwise there will be a lot of bleeding. I am sorry for this, but the connection, I don't know. I mean, it is pretty clear here, but can we just... So once you have this intermuscular plane, you coagulate these vessels, and then you are on, once you coagulate, you are on the femoral neck. So you need to place the retractors, levers there, and okay, we all are helpless. So these 4 levers are on the superior portion of the neck, inferior, one on the greater trochanter, and one lever goes in between the rectus and the capsule, okay? And these are the special retractors you need for that, and this is how these retractors are placed. So this is the place where, so these 4 retractors are important. Then the femoral neck is in front of you. You can do capsulotomy, and you can do resection of the neck or osteotomy. Early phase of the DA career, it is better to do biscuit osteotomy. Take it out at least 5-7 millimeter of neck. It becomes very easy to remove the head later on. And these are the steps where then acetabulum is in front of you, and after that you come to, once the acetabulum preparation is done, come to femoral preparation. In femoral preparation, this soft tissue releases inferior-pubio-femoris ligament, and superiorly around 12 o'clock. So this is GT around 12 o'clock, and you release vertically, and don't go posterior, don't release the posterior capsule, release vertically. Your abductors are attached on the back side, so release the capsule completely. You can ask your assistant to hold or pull that femur with a bone hook, and then release it, and once the piano test is positive, you can mobilize the femur nicely. That's the indication where your releases are sufficient. And once that is done, you can place these levers around acetabulum and complete the case. So small video, but you'll have to bear with me. I am also helpless. So this is the standard incision for DA, the intermuscular plane. You retract tensor fascia femoris, identify the vessels. It just takes 5 minutes to reach this step. Once you coagulate these vessels, place the levers as we discussed earlier. You are on the femoral neck. Early phase of the career, you can check it on IITV and confirm that your osteotomy angle and site is correct. Take out the bone. After that, with routine femoral head extractor, you can remove the femoral head. Acetabulum is there in front of you. And after that, a routine acetabulum preparation. And then check the trial cup position on C-arm. That is the biggest advantage. Once you place that, confirm it under C-arm guidance, then final cup position. In this case, I use a ceramic liner. And once that is done on the femoral side, this is how we do it. So the the operated leg goes underneath the opposite leg. And then trial reduction, again confirm it on eye, and then the final stability check. And you can confirm it under C-arm. Limb length you can check on table. And that's the final X-ray picture. So once you start doing it routinely, but patient selection is extremely important. And initial phase of the career, always select lean, thin patients. Otherwise, it will be difficult. So this is how you drape it. Adhesive plaster on the lower part of the abdomen, and you should be able to extend the hip properly. Okay, hip extension is, it should be possible to extend it, reverse Trendelenburg position. Then after that, part preparation for both the legs, opposite leg also. So this is a unilateral THA case, but both leg preparation is extremely important. Once that is done, then draping for both the legs. So you will be able to extend and then rotate the leg and take it underneath the opposite leg easily. Once that is done, so you drape it, routine drapes, and then over that you can use a routine bilateral TKR O drape. You can just incise and pull it up. Okay, so this is a routine bilateral O drape there, and IO band. So the preparation, leg preparation is extremely important, and with this technique you can comfortably do DA on a routine table. You don't need special table for that or a fracture table, and this can be easily done. So and the last talk, organizers had given me instruction, you need to save some time for us. So robotics in TK, these are my disclosures, and written informed consent for sharing testimonial videos from all the patients has been obtained. We are shared in this presentation. So technology, friends, I started with Colibri, Brain Lab, then Knee3, GPS, and various technology I have been using since past almost 15 years. But I was a bit skeptical whether to go for robotics or how much it will be useful, because my past experience was not that great. Definitely those machines lacked precision, reproducibility was an issue, and results were not consistent. But so I had these questions which any orthopedician will have. Is it really worth? Will it make any difference? Is it just a marketing gimmick? And I have tried answering all these questions one by one. So robo is a Czech word meaning robota, and meaning of that word is a forced labor. You are asking someone to work for you. So robots are in use in aviation, in military, various industries where you need precision, productivity, and efficacy. First time robo was used in 1988 for neurosurgical biopsy, and same robo with some modification was used for prostate surgery in 1991. After that, for all many abdominal surgeries, oncosurgeries, robos are in use. But first time for total knee arthroplasty, robo was used at Imperial College London. The robo name was Acrobat. And RoboDoc by Think Surgical California was developed in early 1990s. Robos can be classified on imageless or those who need images, CT or X-ray. So Smith and Corey from Smith and Nephew or Wellis from Depew are imageless robos. Cuvis from Curexo, Mako, Rosa, and Miso from Merrill, they are robos where you need some images. Cuvis and Miso are fully automated robos, and other are semi-automated robos. These robos are operated by surgeon himself. Robo use is going up everywhere. This study predicts by 2027, almost 50% TKA will be done using robotic systems. Not just in orthoplasty, but robos will be there in osteotomies, in ligament surgeries, various other orthopedic procedures very soon. So literature we can skip because there is various literature which is available and which says that robotic assisted TKA reduces soft tissue injuries, better implant placement, but functional outcome yet for total knee arthroplasty, there is no significant difference. So we will skip this literature part. But the first question, is it really worth? But Pune being capital of robotic arthroplasty, and we could achieve around 2,000 knees in last 2.5 years. So it definitely has taken my practice to next level. And it gives different perspective. It gives you information regarding rotational component of the femoral side, alignment, different alignment philosophies you can achieve with robotics. And definitely it is a good research tool. We have come up with around 5 papers till now and published these papers where we used different robotic systems. Is it just a marketing gimmick? No, it definitely adds value to your practice. It is a smart assistant inside theater. And it is definitely useful for patients who believe the machine is more important than the doctor. Benefits to the patient, less soft tissue releases, less blood loss, implant placement definitely better than manual, less OPD visits and improved ROM. 2 hours for bilateral. So OT time definitely goes down once your team is aligned and they know what steps to follow. Complications, I was discussing this complication, especially femoral fracture, but we can overcome this complication with this technique where we started putting pins on the metaphyseal region on the medial side, and more than 1,500 cases now, 0 femoral fractures. So putting these pins, this is for Cuvis robo. Other robos, you can put pins inside the wound in the metaphyseal regions, which is safe. For Cuvis, it was difficult to put because we were told to put in diaphyseal region, and it was challenging. So we could avoid. Next point, whether we can use it in severe deformities. Yes, it is possible. So we'll just quickly see these cases, severe deformities, and where it was extremely tight medially. You can see just 3 mm gap on the medial side. It was very, so we had to give varus on the tibia as well as on the femur, increase the rotation of the femoral component, and that's how we do it. So if you see that 2 mm, we increase the tibia cut, and then we increase the rotation, and we could get exact balanced knee 10-10 in the flexion as well as in the extension. So we know what will be the consequences of the bony cuts, which is difficult to predict in manual surgery. So these are the post-op x-rays of the same patient. Pre and post, we'll skip severe deformities, pre, immediate next day and post surgery. So various varus knees we'll skip now. The next question, whether we are able to address valgus knees. So that is again a tricky situation. So we'll just skip this to save time. So valgus knees, yes, it is possible to address valgus knees. So a patient who had 10-year bilateral knee pain, severe knee, and this is one important point I would like to highlight here. So kindly note, I mean the posteromedial resection is 5 millimeter and posterolateral resection is 9.4 millimeter. So I actually internally rotated the femur to balance the knee in flexion. This was a valgus knee. So I was skeptical and I was hesitant whether, but did not have, and so this is the video, intro of video of good patellar tracking of same patient, and where it did not have any problem, post-op X-ray and pre and post-op video of same patient. So as I said earlier, this definitely gives different perspective to your conventional surgery also. Pre and post videos will skip. Very difficult knee, pre and post picture of same patient, and complete correction without any constraint implant here, and we could achieve. So whether to go for saw-based Miller or Miller-based robotic system, there is no difference, I mean, whatsoever in surgical outcome. Another is image-based or image-less. Again, image-less, there are advantages of you don't need pre-op CT or X-ray, less radiation, less expensive. Pre-op planning like this is not required. And if there are any prior implants in the femur or tibia, then it becomes easy for image-less system than image-based system. Disadvantages, you need to locate the hip center intraoperatively, malleolus, especially it becomes challenging in obese patients. Tibia femur cyst you can miss in imageless systems that you can find easily on image-based system. And sagittal plane alignment is definitely better with image-based system than image-less system. So these steps you can avoid in image-based system, femoral head center location, malleolus. Image-based advantages are bony landmarks are clearly identified preoperatively. Cyst and implant sizes, cysts are identified. Implant size you come to know before you enter the theater. Sagittal plane is better aligned in image-based system and rotational also. And so this is one case where we found, I mean, X-ray did not show anything, and but CT image showed huge cyst on the tibial side, and that was a cyst. Fortunately, it was a content defect, and we could get away with extension stem there. But the disadvantages of image-based system are the radiation hazard. It is expensive for the patient because to get pre-operative CT scan, pre-op planning, you need to spend some extra time, and prior implants, if there are any, then it becomes challenging. In our experience, friends, there is definitely learning curve with the robotic system. It is highly precise and less blood loss, less pain, and shorter hospital stay for sure. So take-home message is, you are the boss as a surgeon. Don't allow robo to overrule your thought process. Your conventional knowledge of TK is extremely important. Get your basics right, then only venture into robotics. You're bad, you put the garbage in, garbage will come out. So whatever information you provide to the robo is extremely important. Then only robo will function properly. And definitely it adds different perspective to your routine surgery. Thank you very much.